Okay, hey y'all. My name is Kate, and I'm going to be doing my presentation over epidemic typhus, tularemia, and typhoid fever. These are all diseases of the circulatory system and the lymphatic system, which I believe is covered in chapter 21 of the textbook. So to start out, I'm going to cover endemic typhus, which is also known more commonly as louse-borne typhus. And louse is actually the singular form of lice. I did not know that when I went into researching this infection, so I think that was just important to note. And also, endemic typhus used to be responsible for millions of deaths hundreds of years ago. However, it's now considered more of a rare disease. This is due to a number of factors, which we'll cover as the presentation continues. So the causative agent for epidemic typhus is Rickettsia prowazekii. So this is actually a vector-borne disease, which is transmitted most commonly through infected feces of the body louse, Pediculus humanus corporis. This bacteria is very host-specific. This lack of mobility kind of limits the efficiency of its transfer to different hosts. And it's important to note that body lice can multiply really rapidly, and their population can actually increase by about 11% per day. So in regard to disease mechanism, Rickettsia prowazekii, again, is transmitted from human to human via body lice, and this only occurs when people come in close physical contact with each other. So lice actually become infected when they feed on infected humans. They then ingest this bacteria, which it travels through the lymphatic and bloodstream to the endothelial cells, where bacteria then multiplies. And after multiplication, the epithelial cells burst and the pathogen is excreted through the feces of the lice. Humans then become infected when either the infected lice feces or just generally crushed infected lice enters the bloodstream, usually through small cuts or mucous membranes of the body. And I just think the most important thing to remember is that feces spreads the infection, not a bite itself. So in simpler terms, infection is spread through contamination of a bite site or open wounds, not by being bit by a vector itself. So some patient symptoms, they usually develop between 7 to 14 days after contact with the infected lice. Most commonly, it's around 12 days. And just some general symptoms include high fever and chills, headache, rapid breathing, tiredness, body and muscle aches, cough, nausea and vomiting, as well as the development of a rash. This usually occurs in about half of infected individuals, and it usually begins on the back and chest region and then spreads throughout the rest of the body. And individuals can actually experience a relapsed form of this original epidemic typhus infection. This is known as Brill-Zinsser disease. So individuals will remain infected for years after the initial infection and then be reinfected when the infection reactivates. And this is usually due to like a weakened immune state. So during illness, when taking certain medication, or just due to old age. And the individual will experience slightly milder but super similar symptoms to their previous infection. And this whole path of disease is kind of shown on the diagram in the bottom right. So how to diagnose epidemic typhus? Epidemic typhus has similar symptoms to a lot of other rare diseases. Thus, most health professionals identified the disease based on if the individual has been in a region where spread is common. So just in general, diagnosis of epidemic typhus is usually suggestive in any severe outbreak of unexplained source in unhygienic environments. So these include regions experiencing civil wars, social collapses, or just chronically poor and cold countries. So an example of like a symptom that health professional would see is shown in the image on the right. So this is lesions, which is due to scratching due to the prevalence of body lice on the upper arm of a homeless man. So the correct environment for this disease to occur. However, definitive confirmation of the disease is usually done via blood or skin test, specifically plate microagglutination and indirect immunofluorescence tests. However, usually these take several weeks, so doctors may begin treatment prior to these results occurring. Okay, so in regard to epidemiology, so without antibiotic treatment, the mortality for this infection is around 60%. However, with antibiotics, the mortality is around 4%. And historically, outbreaks of epidemic typhus usually occurred worldwide, but specifically during the Napoleonic, World War I and World War II, specifically among military troops. And then currently, the disease has become increasingly rare due to improvements in living conditions. However, occasional cases will occur in areas of extreme overcrowding, where body lice is able to jump easily from person to person, as well as areas of poor sanitation and hygiene, so within homeless populations, prisons, as well as refugee camps. So in regard to disease control, because lice thrives in areas of overcrowding and improper hygiene, prevention tactics can include bathing regularly and changing clothes often, as well as washing louse-infected clothing using hot water. So lice physiology is really dependent on temperature. So washing clothing at around 50 degrees Celsius is usually sufficient to kill the organism. Also, not sharing clothes, beds, bedding, or towels is important, specifically with individuals who have body lice or have been in close contact with someone who is infected. And also treating bedding and uniforms and clothing with 0.5% permethrin can also kill and provide lasting protection for these specific objects. So some treatment strategies. Antibiotic therapy is most commonly used because it's highly effective. Doxycycline specifically is the most recommended treatment for both the original infection as well as Brill's insert. There is currently no vaccine available, and just something I found interesting that I thought I should note is that endemic typhus is actually considered a bioterrorism agent, specifically because the organisms can remain alive in lice species for weeks on end, and infection can easily be transformed into an aerosol where if breathed in, it can cause disease. Okay, next I'm going to cover tularemia. This is also commonly known as deer fly or rabbit fever. The causative agent of tularemia is Francisella tularensis. This is a zoonotic intracellular pathogen which contains a thin lipopolysaccharide containing envelope, and it's also a hard non-spore forming organism which can survive weeks at low temps in water, moist soil, hay, straw, as well as decaying animal carcasses. There's two main subspecies, so Tularensis, which is type A, and Holarctica, which is type B. Type A is known to be more severe of the two. So this bacteria is found in a diverse range of animal hosts and habitats, specifically small mammals, so like rodents, voles, mice, water rats, squirrels, animals similar to that, as well as arthropods, so ticks and flies. And this bacteria can also be recovered from contaminated water, soil, and vegetation. Most cases occur due to being bitten by flies or ticks, which carry the bacteria, or from exposure to the tissues of infected animals, so when handling an infected animal or by inhaling or ingesting it. Important to note that person-to-person transmission has never been recorded. So the disease mechanism, so as stated earlier, Francisella tularensis is a gram-negative coccobacilli and facultative intracellular pathogen of humans and many animals. It can be transmitted from infected animal to human via multiple routes, and it causes diseases of varying intensities based on these routes, so specifically based on the portal of entry, the infectious dose, and which subspecies of bacteria is doing the infecting. So in regard to the life cycle, Survival and replication within human host cells is a key aspect to the bacteria's life cycle. It can enter, survive, and proliferate within multiple cells, so macrophages, dendritic cells, neutrophils, hepatocytes, and others. However, the ability to replicate within macrophages specifically increases the bacteria's pathogenicity. So the bacteria will enter macrophages by triggering the formation of asymmetric spacious pseudopod loops. It then modifies the pathway of the macrophage, preventing phagolysomal fusion, then escapes into the cytosol and undergoes extensive replication. Cell death then occurs, and the bacteria is released, and the human becomes infected. So just in simple terms, survival and proliferation relies a lot on physical escape from the original phagosome, and replication occurs in the host cell cytosol. So some signs and symptoms for tularemia depend on how the bacteria entered the body. So whether through the skin, through mucous membrane, GI tract, or the lungs. And symptoms usually appear about 3 to 5 days after exposure. And there's some major target organs include lymph nodes, the lungs, the spleen, the liver, and the kidney. So multiple forms of the disease, again, these depend on how the bacteria enters the body. So the most common is ulceroglandular. This usually occurs through bite or after handling infectious animal. And in this form of skin, ulcer appears at the site of entrance. This can be seen in an image on the upper right. And the most serious form of tularemia is pneumonic. This results from breathing dust or aerosols which contain the organism, and it can also occur when other forms of tularemia are left untreated and the bacteria has time to spread to the lungs. Some symptoms include cough, chest pain, as well as difficulty breathing. So in regard to the epidemiology, tularemia more commonly occurs in males. This could be due to the higher likelihood of exposure through activities such as like hunting and performing landscaping. It also occurs in people of all ages, but mostly it can be found in children. In regard to distribution, it's thought to be maintained in the environment principally by various terrestrial and aquatic mammals. And outbreaks of humans is usually parallel to infection of wild animals. So the most common arthropod vectors include biting flies. These can be found in Utah, Nevada, and California, as well as ticks, which populate the Rocky Mountains. It also occurs commonly in rural populations within individuals who spend time as hunters, forest workers, farmers, or walkers. And it has been reported from all states except Hawaii. However, the most common in the U.S. is within the South Central region, the Pacific Northwest, and parts of Massachusetts. So some prevention, which can be taken to control the disease, is that when hiking, camping, and working, it's important to use EPA-registered repellent, as well as wear proper protective equipment, so pants, sleeves, and socks. When mowing and landscaping, it's important to watch for dead or sick animals. And when hunting, trapping, and skinning animals, you should always use gloves and make sure to cook game thoroughly before eating. So on the left map, this demonstrates the prevalence of tularemia in the U.S. You can see that the disease is most prevalent in the south central U.S. region, so within Arkansas and Oklahoma. And on the right graph, this shows the number of tularemia cases from 1950 to now, and one can easily see that the disease was much more common in the mid-1900s and has decreased over time. So rapid diagnosis of tularemia is currently not widely available, and tularemia symptoms can easily be mistaken for more common illnesses, so it's important to notify physicians of recent contact with animals or potential tick and flea bites when developing similar symptoms. Specifically though, tularemia can be identified through examination of secretions, exudates, or biopsy specimens using gram stain, direct fluorescent antibody, or immunohistochemical stains. The primary treatment method for tularemia is through antibiotics, specifically streptomycin. Most patients completely recover when given proper treatment, and if an individual receives treatment during the disease incubation period, then they can actually avoid developing symptoms altogether. So a vaccine has been developed for tularemia, however, it can't be used commercially. It's a live attenuated vaccine, which is derived from type B, and it's mostly given to lab techs who repeatedly work with the bacteria, and it's currently under FDA review to be utilized commercially. Okay, last but not least, I'll be covering typhoid fever. So the causative agent for typhoid fever is Salmonella typhi. This is a bacteria which infects the intestinal tract and the circulatory tract. The higher the ingested dose of bacteria, the lower the incubation period will be, and the higher the risk of infection. This bacteria spreads usually through sewage contamination of food or water and through person-to-person contact via the fecal-oral route. So fecal material from infected humans enters the mouth of another individual. Shedding through fecal matter, so feces or urine, may be temporary or chronic. So temporary, the individual will be contagious for 3 to 12 months, while chronic, the individual is contagious for greater than 12 months. An example of this is Typhoid Mary, which we discussed earlier in the class. Just some general mechanisms that are important to note. So the reservoir for typhoid fever is humans. The portal of exit is the feces. Mode of transmission is vehicle-borne through contaminated water and food. And the portal of entry is the mouth. So the disease mechanism, S. typhi avoids recognition and elimination by patrolling neutrophils. This allows the bacteria to disseminate through an individual's body without being destroyed. So specifically, the bicapsular polysaccharide, which is found on the outer layer of S. typhi, actually acts as a cloaking device and prevents neutrophils from migrating to destroy the bacteria. So after ingestion, S. typhi enters into the small bowel epithelium. This is mediated by cystic fibrosis transmembrane conductance regulator. It then proliferates intracellularly in the submucosa. This occurs initially in the Peyer's patches. It then leads to hypertrophy via recruitment of mononuclear cells and lymphocytes. Proliferation then occurs, and the organism is released into the bile and infects the ileolymphoid tissue. It then disseminates to the liver, spleen, and reticuloendothelial system via the lymphatic system and the bloodstream. So, development of symptoms for typhoid fever usually occurs 1 to 2 weeks after exposure. General symptoms include sustained fever, which means the fever doesn't come and go. And early symptoms usually include fever, just a general ill feeling, and abdominal pain. Some additional common symptoms are weakness, stomach pain, headache, diarrhea, constipation, cough, loss of appetite, as well as a rash, which occurs in the trunk region. This can be seen on the image on the left. These are usually called rose spots. So diagnosis, blood culture is the main form of diagnosis. It's not expensive or technically difficult. However, a single culture is positive in only approximately 50% of cases, thus multiple cultures must be taken in order to make a thorough diagnosis. You can also be diagnosed via bone culture or bone marrow cultures. This is the most sensitive most sensitive test available. And it can remain positive despite antibiotic therapy. However, it is highly invasive and expensive, so it's not used often. And then we also have the Whittle test. This detects antibodies against O and H antigens. It is widely used in developing countries due to its low cost. However, it is unreliable due to a high rate of false positives. So some treatment strategies. Antibiotic therapy is most common, usually through fluoroquinolones. This is commonly used for empiric treatment in adults. However, most infections in the U.S. are acquired abroad, and fluoroquinolone non-susceptibility is common, so antibiotic resistance. Fluoroquinolone non-susceptible infections are usually resistant to the synthetic quinolone nalidixic acid and have been associated with treatment failure or delayed clinical response. So now azithromycin and ceftriaxone are usually used to treat infection. There are 2 typhoid vaccines that are available and licensed in the US. The first is the intramuscular bicapsular polysaccharide vaccine, and the second is a live attenuated oral vaccine. Both protect around 50 to 80% of recipients from being infected. And this vaccine is recommended for individuals who are planning to travel to areas with high risk of exposure. And these are my references for all 3 of the diseases. Thanks so much for listening.